The Center for Immuno-Oncology was created many years ago with the initiative of Dr. Steve Hori. Dr. Steve Hori is the director of the melanoma program, the disease center at Dana-Farber, and was one of the pioneers in the field of immunotherapies in cancer. One of the most successful trials that he led was using anti-PD-1 therapies in, obviously, melanoma cancers. And before, when melanoma gets very aggressive, right, later stage of melanoma, there was a 4% survival. So that says a lot about how aggressive it is. With anti-PD-1 therapies, Keytruda is 40% survival right now. Due to clinical trials like that, Dana-Farber, together with Dr. Hori, say, all right, these drugs not only target, the cancer cell, but they target the immune system. So why this shouldn't work in all the other cancers, right? When the immune system is stable, obviously you have different antigens, different mutations. It's very complicated, but they foresee this happening. All these disease centers start trying all these immunotherapy drugs. So Dr. Hori said, all right, let's centralize everything. Let's hire the expertise, let's develop expertise, let's centralize all the management of the clinical trials, as well as the data production. And that's how the CIO, Center for Immuno-Oncology, was created. Pretty much right now, the CIO within Dana-Farber, and even Mass General Hospital, Beth Israel, Brigham, is the focal point for immunotherapy clinical trials in cancer. Right now, it provides not only the technical support, but the expertise to develop these clinical trials. Don't forget that many types of cancers, people are still using chemotherapy and radiation, for example. So they come from a different world, and this is a very immunological-driven world, the immunotherapy. So they need our help to say, all right, what we're going to measure and when we're going to measure. When are we going to collect the blood of the patients? What are the antibody panels? What soluble biomarkers we're going to look for? And that's what the Center for Immuno-Oncology is for, right? So the Center for Immuno-Oncology has 55 people right now. 2 different labs, a pathology lab that gets, all the tumor tissue and perform immunohistochemistry and nanostring and all those cool technologies. And then is the immune assessment lab, which is the lab that I led, that we get the blood samples and we get some biopsies when they're big enough that the pathology would like to share with us, and we created cells, single cell suspension with those biopsies. The lab has been open for 3 years. They gave me 3 years ago the keys to an empty lab. Empty meaning empty. Was one computer there. And well, they gave me a credit card. So I started doing shopping. And well, the lab became functional 3 months after that. Some things are custom made. It's not like you buy a -80 and it's in a warehouse, and they have to put it together. Same with the sequencers and many other things. 3 years from that day, we have collected 4,000 blood samples. And what we do with those samples is we separate PBMCs from plasma and serum. We bank. We bank absolutely everything. Those samples come from patients right now, they're participating in more than 25 clinical trials and research collection protocols. Research collection protocols are those that the drugs are already approved, and the patient consent to give tissue for research purposes. Those patients come mostly from melanoma. I would say 30% of them, because of Dr. Hori, relationship to is the leader of both, the Center for Immuno-Oncology and the Melanoma Disease Center. But then we have sarcoma, glioblastoma. Now we started with non-solid cancers like multiple myeloma and lymphoma, and breast, kidney, and ovarian cancer. So right now we are studying 15 or 13 to 15 different types of cancers. It is impossible to become an expert on cancer when you do this kind of job. So it's because you cannot learn absolutely everything about every type of cancer. So the lab, as I said before, is what in other places is called immune monitoring lab. So it's all immunology. What do we have in the lab? What technical capabilities? Obviously, it's a regular lab where you have the fume hoods and the biosafety cabinets, and we use those to 5-color samples and to purify the PBMCs and separate from the plasma. Sometimes we do some in vitro stimulation assays when the clinical trials requires. Usually they're vaccines. But it's mostly, we freeze everything. And when we collect enough number of samples, or we finish with that collection, we're talking about phase 1 trials, we do the assays in 1 day. So we don't deal with batch effects. All the soluble biomarker flow cytometry CyTOF is done in 1 day. Then we take 3 months to analyze the data. But that's a different story. We work very closely with the Dana-Farber flow cytometry core. They have 8 to 10 analyzer sorters and 2 CyTOF machines. And now we just bought a MIBI. A MIBI is a CyTOF type imager. It costs $1.6 million. So imagine pathologists, right? is heaven, because in 1 microslide you have 40 markers. It's a very cool technology. I hope they get it to work. We also have a sequencer, an ion torrent, and the ion chef that help us to make the library. And the reason that we have a sequencer, because in my opinion, we needed a discovery tool. When we do flow cytometry, CyTOF, Luminex type assays, we are choosing the biomarkers that we want to look for. We are, say, staining for interferon or measuring IL-2, et cetera, et cetera. But if you do a transcriptome, for example, out of a CD4 or a CD8 cell, you have 21,000 genes. The cell is going to tell you what the cell is making. Then you can gather that information and go to the proteomics side and play with your CyTOF panels or your soluble biomarkers. So that is a very nice toy to have in the lab. And we have, ELISA readers, very useful in cancer vaccine development, because, a lot of people measure interferon gamma, which is one of the main biomarkers in immunotherapies. And we have a play reader. And it's funny because we have a play reader and a watcher for ELISA because of one biomarker that none of you guys in the back have as a multiplex, which is interferon alpha. So we have to do one ELISA, and for that, we need the plate reader. And I'm not going to say this because this is a Luminex organized meeting. The rock star in the lab is the MAGPIX. Thank you. In 3 years, we have published 8 papers. 7 of them are about soluble biomarker detection by Luminex. And there's a reason for that. When the immune system of a patient under immune therapy, and we're talking about PBMCs, so don't ever forget that is 99% of what we do in the lab. Nothing is going on. It's flat when we talk about immune phenotyping. It's not that you're going to see much more activated CD8s or natural killers, for example, which are two of the main phenotypes that we look for. Those get activated, hopefully, in the tumor when you have antigen presentation. So that's why when it comes to flow cytometry, the research that we do in the lab is pretty boring because honestly it's flat, but we still have to do it. But there are a couple of biomarkers. They are soluble that you can see in circulation. Usually they are chemokines. So right now, well, I'm gonna talk about a few research examples, but first a little bit about the history of the Luminex. We bought it when I opened the lab, and one of the reasons that we bought it is because it requires a minimum number of a volume of samples. Even though that we get, in an average, 30 mL of blood per patient per time point during their treatment, we usually harvest around 8 to 10 mL of plasma. I say, well, Mariano, you could do so many ELISAs and stuff like that. But the thing is, we don't bank thinking about only what we can do today with the sample. These are clinical samples that are gold. So we need to save these samples for future research. And I was talking to some of my colleagues today and say, all right, but you're going to use 50 to 100 microliters for Luminex, several plates and duplicates or triplicates. So you still have like 9 mL. Well, right now we have a collaboration with MIT that we're looking for T-cell receptor sequencing out of free DNA in plasma. That requires 8 mL. So that doesn't leave you much left, right? So when we collect all these samples, we have to think about today, and we have to think about what technologies can come up next year that we're going to need it. Every time we run the Luminex, we calibrate the machine, we clean it, we spend a lot of the calibration reagent, even when you have to do it only once a week, according to the experts here. We still do it every time, pretty much every day when we turn the machine on. And as I mentioned before, we try to do everything in one day. So we don't run one sample, we run a whole phase 1 trial altogether. Right now, we have validated more than 150 biomarkers, and those biomarkers include Th1, Th2, cytokines and chemokines, with a lot of angiogenesis and growth factors related to cancer. But what do we use the Luminex for? Obviously, to identify these biomarkers, right? Biomarkers that help us to understand what is the effect of the drug, the biological effect in the immune system. Also, to perform correlative studies. A correlative study is when you add those biomarkers to the clinical outcome of the patient, right? If you have 100 patients, right, all getting the drug, you say, well, yeah, you have IP10 or IL-8 family members going up, yeah, after treatment, but how that relates, how that becomes a biomarker? Well, you have to put that data together with the clinical outcome and say all the patients responding to this treatment have higher levels of IP10. And that is an example of correlative studies. And that happens not only in blood, it happens in tissue too. We also use it to verify other technologies, to verify data that comes from other technologies. As I mentioned before, RNAseq or transcriptome or targeted sequence that tells you about gene expression data, and then you need to corroborate it by protein. But also to validate other protein-based technologies like flow cytometry and CyTOF. And I'm going to get to an example later on. All right. This is a very small summary of Immuno-Oncology, if you want to call it like that. So this is a picture of the tumor, what is called the tumor microenvironment. And you have few key players here. You have the tumor cell, obviously. The tumor cells they die, they divide, obviously, faster, but they also die. And they release antigens. And they're releasing antigens even when they're alive, obviously, because have mutations and stuff like that. Antigen-presenting cells, macrophages, dendritic cells, they capture those antigens, they present it to in this case, a T cell, a CD8 T cells. The T cells get activated, and hopefully they do the killing that they need to do. The problem here is that, well, there are two problems. One is that you have immune cells in the tumor microenvironment that they want to shut down the immune response. You have Tregs, you have MDSCs, everything is trying to shut it down. And also, you have the tumor cell expressing a lot of these inhibitory proteins and ligands, right? That in this case, the CD8 comes and say, well, the tumor says, I'm expressing PD-L1, so I'm going to hit your PD-1, and that is a dead signal. And that's how it happened. And then, the activity of your CD8 cell or your natural killer, is affected. So these, I'm giving an example here of two of the markers, which are PD-1 here and CTLA-4. Those are very good, receptors for these inhibitory signals. And the tumor cells is capable of producing those ligands. An important thing here is, as you can see, there are a bunch of cytokines here, like, you have interferon and perforin and granzyme. Perforin and granzyme is not something that you're going to find a lot in plasma because it's very, they work in contact. The CDAs always have it and they get released, but to get the release, they need to be next to the tumor cell. And same with interferon. So they're, very localized proteins, and it's very hard to find them again in circulation. Now we're going to get to a few examples of data that we have produced. This is a very interesting paper for two different things. The main one, when the hematological malignancies group submitted this paper to the New England Journal, the reviewers came back to them and said, yeah, it looks great, but we would like some mechanistic data. So it was like, without mechanistic data, we are not going to accept it. So they called me. They said, Mariano, you want to be in a paper? Sure. I never imagined it was going to be that one. And say, all right, we have serum, can we do a chemokine assay? So sure. So in one day, we made a panel with a lot of IL-8 family members. IL-8 is a very important chemokine, and a bunch of pro-inflammatory cytokines, and we measure. I mean, it takes, as you know, a Luminex assay takes 6 hours. That is one of the interesting things about that paper. I mean, and they put my name on it, so thank you, these guys. The other thing is, some hematological malignancies, advanced ones, transplant is the only possibility of cure. But what happened with those patients, and I don't want to get much into the clinical part because I'm not a doctor. So, but what happened is some of the patients, the cancer comes back, right? And that is a problem for that patient because I don't think you can get a second transplant. So what they did is they treat these patients with EP, or anti-CTLA-4 from Bristol Myers, and a lot of them got cured, right? And that's what becomes interesting, is what is happening here? What it looks, I don't know if you ever heard about graft versus host disease. Usually when you get a transplant, it's the transplant that reacts to your body, right? The immune system of the tissue that comes with the transplant reacts to your body. And that is exactly what happened here. And obviously, these two chemokines, they are very important for leukocyte migration, tell us a lot. And as you can see here, you have two different chemokines. Both of them are members of the ILA family. And you have two sets of patients. You have the non-responders and the responders, right? And you have 2 time points. And as you can see clearly, and obviously it's statistically significant, in both cytokines, the non-responders have a decreasing level post-treatment versus pre-treatment, and the responders have an increased levels of these cytokines. So that was part of the mechanistic work that was added to complete the story of this paper. Another example is from head and neck cancer, and we know that there is a possible synergy between radiation, immunotherapy, and some angiogenesis factors. When you hit a tumor with radiation, in this case, a lot of the cancer cells hopefully will die, and they will release a lot of antigens, and that's why immunotherapy can play a role, because you need to boost the immune system to, so they can recognize the antigens, and whatever is left, hopefully the immune cells will take care of it. Angiogenesis factors, they are also affect the immune system. If you think there are monocytic cells, for example, that they express Tie2. Tie2 is a very important factor, a receptor in angiogenesis, for some angiogenesis factors. And it's been known that, those are associated with responses to immune therapy. So in this case, serum and cells too, it's just that this particular paper is focused in the serum analysis, was collected from head and neck squamous cell carcinoma. It was a phase 1 trial, so we have around 25 patients. And we measure more than these 4 angiogenesis factors and growth factors that you see here. It's just that we couldn't find anything in all the other 25 things that we find, no much interferon, obviously, you never see that one in blood, or TNF, or IL-6, or IP10 was flat. But there were some interesting difference in VEGF, angiopoietin 2, 1, and placental-like growth factor, which is very important in angiogenesis during the development of a human being, but is also is known to play a role in adulthood. So here we have data from the same patients and these 4 angiogenesis factors. As you can see here, you have the 2 angiopoietins in the top, and then VEGF and PLGF. Again, pre-treatment, and in this case, 2 months post-treatment. I think that's the time point. VEGF and angiopoietin 1 levels decrease after post-treatment, while PLGF and angiopoietin 2 increases after treatment. And that is classic. When you have angiopoietin 1 and VEGF changing, the other angiopoietin that is left is gonna compensate for that. So we always see something like that. But in this case, the correlative study shows that PLGF was associated with disease progression. The other approach of our use of Luminex technology, as I mentioned before, is to validate other technologies. As I mentioned a few minutes ago, immune phenotyping is extremely important in cancer immunotherapy. CD8 cells, cytotoxic cells, they do the killing together with natural killer cells, and through cytokine release. As you know, a CD8 cell first release perforin, makes a hole in the membrane of the target cells, introduces granzyme B, which is a protease, and the target cells die. In this case, we wanted to develop a multicolor antibody panel for a functional CD8 cell, to detect functional CD8 cells. So we included what is called lineage markers, CD3, which is a T cell receptor, CD4 core receptor, CD8, and CD56, which is a natural killer marker. In this case, we use CD4 and CD56 as a negative, what is called a negative gating or a dump. So because we don't want to measure, the intracellular markers of those particular cells. So the functional markers are interferon gamma, which is the biomarker by excellence in immunotherapies. MIB1 beta, which is an activation marker of CD8 cells, perforin, and granzyme. This was done using normal donors PBMCs activated with anti-CD3 and anti-CD28 dynabits. They kind of work like an antigen-presenting cell. And the cells were cultured for 24 and 48 hours with these beads, 6 different donors. And here, you have all the fold difference between all these activation markers, perforin, and you see, numbers go crazy. But this in cancer will never happen. Seeing this difference will never happen. At least in blood. The problem with this type of assays in a normal or a clinical environment is that a lot of these cytokines are pre-made already. So when you stain, if you don't use Golgi stops or these compounds just to accumulate signals, or you don't see it, or you don't see a difference. So we figure out, all right, let's try to measure the same proteins, the same factors that the cells are being released. And we apply this Luminex just to measure interferon, MIB1 beta, perforin, and granzyme soluble in the supernatant of these cells. And this was very, very helpful to tell us that what we were seeing by flow cytometry was real. And here you can see all the cytokines you have, the 6 different donors, and untreated cells, 24 hours and 48 hours treated, and a nice a time course for each donor. And, obviously these things get accumulated in the supernatant. The media is never changed. And so now every time that we develop a flow cytometry panel, we try to use Luminex just to have to verify that what we're seeing is real. All right, what I can conclude about Luminex technology, as I mentioned before, is extremely important in my lab. Generates a lot of data in one day. We usually measure, we divided 50 analyzed in 2 or 3 panels, and and we run it in one single day. You have a lot of markers to choose from, hundreds literally. It helps a lot to understanding the mechanisms of how these drugs work. And hopefully, with these correlative studies, this technology can help, to future drug development. There's one, there are a few things that in my opinion could be improved, and in this case is, one example is interferon gamma. We can never see it in circulation, but that doesn't mean it's not there. It's just that, in my opinion, the technology is not sensitive enough to measure those little amounts of interferon in this case. So instead of interferon, we work with IP10, which is a chemokine related to interferon. We are not worried much about the interferon thing because, also when you treat a patient, the next time the patient comes to get a follow-up or the second treatment is a month or 2 months after. So if it was an interferon response going on that you could see in plasma, it's long gone by then. But, it would be nice to have it. The same with interferon alpha, that is not available in Luminex format. All right, I would like you to say thanks again to all of you and to my team at the Immune Assessment Lab. Thank you.